Good evening, everybody. Welcome to this ASCO 2024 BTOG update. Thank you all very much for tuning in on a Monday night to discuss all things lung cancer from North America last month. My name is Tom Newsom-Davis. I'm a medical oncologist, Chelsea Westminster Hospital in London. I'm also the chair-elect of BTOG, and I'm delighted to be joined by some fantastic colleagues to give you an update of what we heard about in Chicago last month, all condensed into an hour and 15 minutes of your time. So before we kick off, I'm going to tell you a little bit about BTOG, because if I didn't do that, Dawn would beat me up. So here we are. BTOG, we would love you to come and join us as a member. If you'd like to do that, you can do that through the website listed there below, and it's free to be a member. I'm sure you're probably all members already, but if you're not, you can join up there. And as ever, if you've got any questions about BTOG, you've got Gina on the left and Dawn on the right, who you can contact through the email there, and they can set you right. So before we kick off and before I introduce my co-speakers, we're very keen this is interactive. The idea is we're going to have 3 talks, go through some data, and then you can ask questions, and you can do that through the chat function. And the great thing about that is if you're feeling shy, you can make it anonymously, and it'd be great. If you'd like to put your name down, that'll be even better. We love questions, and the more the merrier, frankly. If you answer your feedback, you can also get a certificate of attendance. And what more could you possibly want? And when you're doing your CPD diary, if you're a doc, like I'm meant to do this week, I've done it a bit late, that's the code for the RCP approval for this CPD event. So we've got an agenda. You had seen on the advert there were 4 smiling faces at you, and you probably realise there's only 3 smiling faces at the moment. So unfortunately, Yvonne Summers was not able at the very last moment to go to ASCO, and therefore we felt it a little bit unfair to ask her to give an ASCO highlight. I have heroically and very generously, if I say so myself, stepped into her role. So we're going to kick off, first of all, with Louise Lim, who's a consultant medical oncologist at St Bart's Hospital, who's going to talk to us about all things targeted therapy. There was a lot going on. It really was an extraordinary event and an extraordinary year. 2 of the plenary sessions were lung, and all of our colleagues who treat other tumour types were coming across saying, it's amazing what's going on in lung cancer. So Louise even is going to tell us a bit about the targeted therapies. I'm then going to tell you about things immunotherapy and antibody drug conjugate. And then Riyaz is going to be Shah, who's consultant medical oncologist at Kent Oncology Centre, is going to tell us about the locally advanced disease, small cell and meso. And unusually for an ASCO, that's where a lot of the really big data was. So that is what is coming up. And then we've got about 15 minutes at the end for a bit of a chin wag, as they say. So without further ado, I'm going to introduce Louise, who's going to tell us about all things targeted therapy in no more than 20 minutes. Thank you very much, Louise.
Thank you so much, Tom, for that kind introduction, and good evening, everyone, on this really sunny day in London, which is unusual, as you know. So I've got the task of giving you the ASCO update of targeted therapies in advanced non-small cell lung cancer. These are my disclosures. So, as we know, the landscape of targeted therapy has changed quite rapidly in the last number of years, and we now have so many more available treatment options than we've had previously. But for the interest of time and focusing on ASCO updates, I'll be mainly concentrating on these 3 main groups, so the KRAS-based EGFR and the ALK targeted therapies. This table summarizes some of the frontline studies that we've had in the ALK targeted space. Our current frontline standards are in the form of alectinib and brigatinib, both based on randomized phase 3 studies, the ALEX and ALTA-1. And at ASCO this year, we had the updated 5-year survival of the CROWN study, which looked at lorlatinib against crizotinib. So just to remind everyone, the CROWN study was a randomized global phase 3 study, which looked at patients who were treatment naive with stage 3B or 4, ALK positive non-small cell lung cancer, who were then randomized in a 1-to-1 ratio to receive either lorlatinib or crizotinib. The primary endpoint was progression-free survival, and no crossover was allowed between either of the treatment arms. And these were the results. As you can see, at 60.2 months, the median follow-up for the progression-free survival for lorlatinib was not reached, compared to 9.1 months in the crizotinib arm of treatment, with a hazard ratio of 0.19. And as you can see, on the 5-year mark, the PFS rate in the lorlatinib treatment arm was 60% against that of crizotinib at 8%. This PFS benefit with lorlatinib was observed across all patient subgroups, favoring lorlatinib over crizotinib. And so we put this into context and comparing it to our frontline agents of alectinib and brigatinib, you can see that whilst the median PFS of lorlatinib has still not been reached at 60.2 months, this compares starkly to alectinib with a median PFS of 34.8 months and brigatinib at 30.8 months. Lorlatinib also showed superior PFS benefit irrespective of the presence or absence of baseline brain metastases, and at present, the median PFS has not been reached in either of the lorlatinib groups. There were no new safety signals identified from the CROWN study. Most of the adverse events that were grade 3 or 4 were in the patients that developed hypercholesterolemia, hypertriglyceridemia, and weight increase. However, with early modifications of the drug and patient counseling, these adverse events were managed well. So moving on now to the EGFR landscape of therapy, I'm mainly going to be concentrating in the stage 4 lung cancer group, but also the unresectable stage 3 group of patients. So again, this table summarizes some of our frontline data. Currently, our frontline standard treatment is osimertinib based on our FLORA study. And most recently, we have had 2 positive frontline studies. So the Mariposa study, which looked at the combination of amivantamab, which is a EGFR MET bispecific antibody, with lazertinib, another 3rd generation TKI. And this showed that the combination had an improved median progression-free survival over osimertinib. FLORA-2 was the addition of chemotherapy to osimertinib, and that also showed an improvement in median PFS. So amivantamab has been seen to be effective in numerous combinations and in different patient population groups. However, one of the challenges with giving intravenous amivantamab has been its very challenging dosing schedule. So it needs to be given in its first dose over 4 to 6 hours. It's normally given as a split dose over 1 to 2 days. And it's also associated with a very high risk of infusion-related reactions, which obviously makes it very, very uncomfortable and distressing for our patients. And so the Paloma-3 study was designed. One second, my clicker doesn't seem to. So the Paloma-3 study was designed to see if we could improve on this. And this looked at standard intravenous amivantamab plus lazertinib, and it was compared against subcut amivantamab and lazertinib. Patients who were enrolled had progressed on both a TKI and platinum-based chemotherapy, so it was a second-line study, and it was in locally advanced and metastatic setting. The primary endpoints were 2 pharmacokinetic co-primary endpoints. It was the concentration trough level at cycle 2, day 1, and also the concentration area under the curve. Both of these co-primary endpoints were met with a geometric mean ratio of 1.15 at the trough concentration level at cycle 2, day 1, and the geometric mean ratio of 1.03 at the area under the curve at cycle 2. And there was also what looked to be quite interesting overall survival signal. However, the data is immature and it's difficult to very much interpret more from this. However, what was extremely interesting was the safety profile of subcut amivantamab compared to its intravenous form. As you can see, there was a 5-fold decrease in immune-related reactions in subcut amivantamab compared to intravenous amivantamab. The rest of the adverse events were also reduced in the subcut arm, and more importantly, venous thromboembolus, which was a AE of interest, was also found to occur at a lower rate in the subcut arm of treatment, irregardless of whether or not patients received prophylactic anticoagulation. So we know that the combination of amivantamab together with lazertinib has shown activity with classical EGFR mutations via our Mariposa study. We've recently had approval with uncommon EGFR mutations such as exon 20 insertions based on the results that have come up from the Papillon study. And now the question is whether or not we have activity against atypical EGFR mutations, which are rare, but still a challenge for us to treat as oncologists. And so the Chrysalis-2 study, which is a phase 1/2 study, was designed to see if this would be the case. So this was a multi-arm, multi-cohort study, and the cohort C particularly was the group that looked at these atypical mutations who had either had treatment in the form of TKIs and chemotherapy in the past, or they were treatment naive. 109 patients were recruited into the study, and as you can see, there was a clear overall response rate of 52%, irregardless of the line of treatment that these patients had had. And so showing that there is clearly activity of this combination in atypical EGFR mutations. Moving on now to the unresectable stage 3 EGFR mutation positive non-small cell lung cancer patients. So we know that the standard of treatment at the moment for these patients is with concurrent chemotherapy and radiotherapy, followed by maintenance durvalumab as per the specific trial. But as we know with EGFR mutation positive patients, checkpoint inhibitors with or without the addition of chemotherapy do not bring about a very good response in these patients. And so the LAURA study, which was one of the plenary sessions at ASCO this year, was designed to see if this could be approved on. This was a phase 3 double-blind study where patients with locally advanced unresectable stage 3 EGFR mutation non-small cell lung cancer with no progression after definitive chemo-rad were randomized in a 2-to-1 ratio to receive either osimertinib or placebo. The primary endpoint was progression-free survival, and tumor assessments, including baseline MRIs and sequential 8-weekly MRIs, were done to investigate the development of brain metastases. This was the results, and as you can see, it was a positive study with a clear improvement in median progression-free survival in patients treated with osimertinib, with a median PFS of 39.1 against the placebo arm at 5.6, with a positive PFS hazard ratio of 0.16. And at the 2-year landmark, you can see that the progression-free survival rate was 65% in osimertinib and 24% in the placebo arm. This progression-free survival was seen across all subgroups favoring osimertinib over placebo. There was also a clear objective response rate in the osimertinib group of patients compared to the placebo, with a median duration of response of 36.9 months compared to 6.5 months in the placebo arm group. Interim analysis of overall survival is still immature. However, it is important to note that at this point where the hazard ratio was taken, around 81% of the placebo group had crossed over to receive osimertinib. Based on these results, in my opinion, the LAURA study is practice changing for our stage 3 EGFR mutation non-resectable cancers. It is important to talk about adverse events. Most the most common AE in both arms was radiation pneumonitis, majority were low grade, non-serious and manageable. Moving on now to the KRAS mutation landscape. So we know that KRAS mutations occur in about 30% of adenocarcinomas, with the main subtype being that of G12C. We currently have two drugs in the second-line setting that have been approved. So sotorasib via the randomized phase 3 study CodeBreak 200, and adagrasib, which we only had phase 2 data, but we did have the randomized phase 3 updated results in ASCO this year. And to remind everyone, this was the study design. So Crystal's 12 was a randomized phase 3 study looking at patients with non-small cell lung cancer KRAS G12C mutation who had been treated with platinum-based chemotherapy and PD-L1 treatment, who then went on to have either adagrasib or docetaxel. The primary endpoint was progression-free survival. Crystal 12 was a positive study, and as you can see, there was an improvement in PFS in adagrasib, 5.5 months, against docetaxel, 3.8 months, with a hazard ratio of 0.58. And at the 6 months cutoff, the median PFS was 45% in the adagrasib arm of treatment, compared to 30% in the docetaxel treatment arm. There was also an improvement in tumor response, with a 32% overall response rate in adagrasib compared to docetaxel. The most frequent adverse event seen was diarrhea. However, this was low grade in terms of its toxicity, and was managed with dose modifications and dose interruptions. So looking at the current treatment options that we have in the KRAS space, adagrasib and sotorasib as monotherapies in the second-line setting, we get gains of between 1.1 to 1.7 months. And really the question is whether we can improve on this and improve the way we treat KRAS cancers. We're looking at different combinations to improve on this. One of these combinations is potentially looking at olmorasib, which is a second-generation KRAS, which is thought to have a better tolerable side effect profile in conjunction with pembrolizumab. Now, we know KRAS inhibitors can modify the immune tumor microenvironment and upregulate PD-L1 expression. And so this is thought to be a reasonable combination. And as you can see in this phase 1/2 study called LOXO-ROS 2001, we combined olmorasib and pembrolizumab together. And you can see that in the first line and previously treated patient groups, there was a clear objective response rate in 77% in the first line group of treated patients and 40% in the previously treated patients. And this was irregardless of PD-L1 status. The toxicity profile was manageable, and it's being taken forward as a randomized global phase 3 study, the SunRay-01 study, which looks at patients who are either PD-L1 positive, more than 50%, or negative, and they're combined with either single agent pembrolizumab or pembro and chemotherapy. There are concerns about potential synergistic toxicity with PD-L1 inhibitors and KRAS inhibitors in terms of LFT dysfunction and diarrhea. And so one of the other synergistic points is whether or not we can join these drugs, KRAS inhibitors, with chemotherapy. And the phase 1b CodeBreak 101 study has looked at this. This is a multi-arm study, again, with different combinations, looking at different cohort groups. So this looked at the combination of chemotherapy plus sotorasib. And once again, it did show that there was a overall response rate more in the frontline setting with chemotherapy and the KRAS inhibitor, but certainly there was a disease control rate of 100% across all treatment groups, which is quite encouraging. this is also being taken forward as a global randomized phase 3. I understand that they're going for registration potentially with this study. Hence, it's a large patient group of patients. They're hoping to recruit 750. They're going to be randomized to either receiving sotorasib plus chemotherapy, or immunotherapy plus chemotherapy in KRAS G12C positive advanced and metastatic non-small cell lung cancer. So, in summary, I hope you've enjoyed hearing about some of these updates from ASCO. I think they're quite exciting, and for me, at least two of them are immediately practice changing, and I'm very grateful for your attention. Thank you so much.
Thank you very much, Louise. That is fantastic, and a very clear and get my video working. There we go. A very clear and calm reflection. I should just say to people that when you get the email from me saying, "Please, can you do an ASCO update?" it's about the last thing you want, because going to ASCO is actually, despite popular opinion, really hard work because you're jet lagged. Things start very early, they go on very late. You're basically working about 8 to 12 hours a day. And then you get home and all your clinical work is there, and it's complete chaos. And you're thinking, I've somehow got to get all that stuff into a format to present. And it's really, really hard work. So I'm hugely grateful both to Louise and to Riyaz for doing this. Riyaz for doing it for so many years in a row, and Louise for being the first time. You've done it so well. Guess what? I'm going to invite you back. You lucky thing. So I'm going to move on to immunotherapy and ADCs. I'll remind people to submit some questions. There's some really interesting data there on lorlatinib, some practice-changing data on the LAURA study, the new data coming through from KRAS. It's really great stuff. So put your questions in and I should be able to see them and field them. Whilst you're doing that, I'm going to tell you a little bit about immunotherapy and ADCs. There were quite a few exciting things coming through. So I'm just going to see if my internet clicker works. There we go. There are my disclosures. So I'm going to tell you about 5 studies, and these are really the 5 headline ones. I'm going to tell you about the Adriatic study, which is a new standard of care in limited stage small cell lung cancer. And assuming it gets approved in the UK, and I hope it will, this will change what we do. I'm going to tell you about Luminosity, which is a study of an antibody drug conjugate which has activity and lots of potential, therefore, but toxicity. I'm going to tell you about a really interesting study called Harmony A, which might be the first time we've seen immunotherapy really work in EGFR mutated lung cancer. There's an academic study called Icarus, which is understanding how TROP2 ADCs work, or maybe don't work. So TROP2 ADCs we heard a lot about last year from ESMO. This is a very interesting study looking at some biomarkers. And finally, I'm going to tell you about some brain data from a drug called tarlatamab, which we discussed at the ESMO update last year. I'm sure you were all tuned in. And this Delphi 301 study has produced really interesting evidence of activity of this drug. And I'm going to show you some brain activity related to that. But first and foremost, I'm going to tell you about small cell and the Adriatic study. So this is limited stage small cell lung cancer, not something I think, sadly, we see very much of. Small cell is always extensive stage, but we do sometimes see limited stage. This is what's felt to be amenable to concurrent chemoradiotherapy. On the left-hand blue box, you can see stage 1 to 3, and they have not progressed after concurrent chemorad. Prophylactic cranial irradiation, or PCI, was permitted if people wanted to do that. And for the radiation oncologists in the audience, either once daily or twice daily radiation was permitted according to investigator choice. And then the bit we're interested in this data is after that, they got either placebo or durvalumab, the PD-L1 inhibitor. There was also a durva and tremi arm. Tremi is their CTLA-4 inhibitor, but that data is not presented here. And that went on for up to 2 years. So what did the data show? Well, the data showed, and this was a dual primary endpoint, an improvement in overall survival. And this kind of came out of the blue. I wasn't really expecting this. It wasn't really on my radar. Adding durva or atezo in small cell extensive stage, nah, bit of benefit, but it's not dramatic. That's really not a bad improvement in our hazard ratio, and the median overall survival is significantly longer. Quite big numbers, in fact, big numbers for a study like this. This, I would say, is statistically significant and clinically meaningful. So an almost 30% improvement or decrease in the risk of death or the hazard of death. So I think that is a big result. Lots of people cheering. This was in the plenary sessions, a lot of Americans clapping, a lot of Brits looking embarrassed. It was fantastic stuff. What about the overall subgroups? Well, basically, if you run your eyes down those dots, you can see they're all within the blue line, meaning pretty much everyone is benefiting from it. I would draw your attention to about 3/4 of the way down where it says prior chemotherapy regimen. You can see that the hazard ratio for carbo-based chemo is better, 0.56, than that of cis-based chemo, 0.82, meaning those patients that had on carbo were benefiting the most from this regimen. I would put it to you, ladies and gentlemen, we should stop giving our patients cisplatin for small cell lung cancer. I personally think we stop it for everyone, but definitely for small cell lung cancer. It's a horrible drug. It makes your fingers and toes go numb. It makes you sick. It takes up hours of chemo chair time. Let's get rid of cisplatin from small cell limited stage. What about the adverse events? Now, we all know the potential risk here is going to be pneumonitis. They've had concurrent chemoradiotherapy. You give them up to 2 years of adjuvant durva. We're pretty used to that now in non-small cell, aren't we, with the Pacific regimen? Yes, there is an increase in pneumonitis. Not so much the radiation pneumonitis at the top there, but run your eyes down to 3/4 of the way down in bold, and you see that 10 and a bit % of people on the durva arm got pneumonitis, of which a higher proportion had grade 3 or more in the dark blue than those on placebo. So there is, but I don't think that's a particularly concerning increase in toxicity. And the others are very much what we would expect in line with immunotherapy. So not to belittle side effects, but I think these are manageable. So what's my thought on the Adriatic? I think this is a practice-changing treatment. I think limited small cell is rare. And actually, I think what we're kind of getting is it's probably a different process to extensive stage. There's some very interesting data on breaking small cells down into different molecular types. And I think we begin to see, if we look at that, that maybe limited stage is not just I've caught it early, but maybe a slightly different disease process. Hence, the immunotherapy perhaps working a bit better. There were some caveats in this study. We did clarify what is concurrent chemo-rad. Now, in this study, they gave the chemo and the they gave the chemo and the radiotherapy on the same day, day one, cycle one, same day. I think lots of us tend to do a bit of chemo first whilst you're planning the radiation, and maybe you come in with your concurrent chemo-rad on cycle 2. Is that going to be permitted? Will NICE approve it? We need to think about that. I think the adverse event data is reassuring, and I think we need to have access to this combination in the UK as soon as possible for our small cell patients, because the prognosis for these guys is unfortunately very poor. So I promised in Luminosity I would tell you about an ADC that's an active but probably a bit toxic, and this is it. So Luminosity is looking at a monoclonal called Teliso-V. Is targeting MET, M-E-T, and they spent a little time a while ago designing this study, trying to work out who's it's going to work in. It's called a stop-start design on the right-hand side there. And they looked at squamous patients and wild-type patients, mutant patients, and they worked out quite quickly that it wasn't going to be working in the squamous patients, and it wasn't really working in patients with low expression of c-MET, c-MET being the target. So they've gone ahead with their go, no-go decision of the data I'm going to show you here, which is in the non-squamous EGFR wild-type patients, what I'm going to show you now. These guys have all relapsed. They're all at least second and sometimes third line non-small cell EGFR wild-type. What do we see? We see a respectable response rate. In the c-MET high patients, it's 35%. In the c-MET intermediate, it's about 23%. So that's not bad. A median duration of response of 7 to 9 months, and that's also not bad. So not groundbreaking data, but this is an antibody which has activity. And the median time to the onset of response is only about 6 weeks. So it kind of gets going quite quickly. So here we have some activity. But in this excellent presentation by Ross Camage, who's ex-UK now in the States, he speaks really nicely. He gave a nice description of the progression-free survival on the left and overall survival on the right. You can see in green the OS may be a bit better in the CMET high patients, a little bit less good in the CMET low patients, certainly the longer-term survival. So I think activity. But he also gave a very clear and open discussion about the toxicity of this drug. And the issues really are neuropathy. You can see in the top there, so a third of patients getting any grade toxicity, and up to 7% getting grade 3 or more. Now, remember, grade 3 is you're beginning to lose function. You can't do your buttons up, you're dropping your pens, you can't do your fine motor things or affecting walking. So that's a bit of an issue. And the other issue is respiratory and pneumonitis. So the treatment discontinuation rate was about 20% in total, and about a third of patients were having grade 3 or more toxicities. And that's something we're seeing with these antibody drug conjugates. They're not benign drugs with just this beautifully targeted drug with no adverse events. You are getting collateral damage depending on what the payload is and depending on what the target is, but mainly what the payload is. If we look a little bit more at that and focusing on the right-hand side, the second bullet point, 10% of patients from 9.9 got ILD, 5% it was grade 3, and in fact, in 3 patients, representing almost 2% of patients, they were fatal ILD events. So definitely a drug with some issues. And you can also see there are some other adverse events of special interest, including not only the neuropathy, but also effects on the cornea as well. So what are my thoughts about luminosity? So ADCs are having a troubled time. We're trying to work out, do they work? Where do they work? What are the side effects? So here to these OV, this MET targeting ADC, I think it's got clinical activity, but it has got toxicity. And the presentation is a nice description way of showing that toxicity data are not shying away from it and being open about it. They are challenging. We've got to work out the risks and benefits. And I think the selection is going to be key. So bit of a signal there with CMET expression. How can we select even better? There is a phase 3 study called Telemet going on versus docetaxel in the CMET overexpressing patients. And it'll be interesting to see what that shows in due course. The third study is Harmony A. So I said to you, this was a study that showed that maybe immunotherapy works in EGFR mutated lung cancer. So these are the EGFR patients. They've had their TKIs, they've exhausted their TKIs, and they're now going to go on to either chemo, PEM-carbo in orange at the bottom there, or chemo plus ivonescimab. What is ivonescimab? It is a dual-targeted antibody with PD-1 on one bit of the Y of the antibody and VEGF on the other. So this is a PD-1 VEGF targeting monoclonal antibody. So how well does it work if you add it to chemo? The answer is it works pretty well. That's a pretty impressive progression-free survival curve. Hazard ratio 0.46 is more than halving the hazard of progression. Look at the 6 and the 9-month data showing that this, so my computer's just started to just blank its screen, so bear with me whilst I just log back in. It does this. There we go. So yeah, it's quite impressive 6 and 9-month data there for progression-free survival. It also works in the presence of brain metastases. You can see those Kaplan-Meier curves, and indeed the hazard ratio is very similar whether you have brain mets on the right or not on the left. So that's important because we know that's a common problem in this type of disease. And overall response rate in dark blue is higher, as is disease control rate in light blue than patients on just chemo in the dark and light red. So definitely an active drug. Overall survival, immature data, but that terrible word, a trend towards benefit. So let's see what this shows. But we can't conclude that it's too immature, but it's very interesting. What about side effects? Now, you will know an alternative to this, because we knew that from ESMO, and I know that you are all tuning in to our BTOG ESMO podcast indeed, and webinar, is the Mariposa 2 regimen. So adding in amivantamab to PEM-carbo. Well, what is this like in terms of toxicity? Well, actually, this is the Harmony A data. There's not much increase in toxicity beyond chemo. There's a little bit, but actually not much. If you look at the dark blue lines, which is the ivonescimab plus chemo versus chemo in light blue, not that much in it. And most of the tox, and the grade 3 tox, is hematological, so it's pretty well tolerated. It's a bit like giving normal chemo, which is not a great thing to have anyone, but it's really not too toxic, I think we probably agree. So what's my thought? Well, look, we know that immunotherapy and VEGF can be active. We've seen that in Empower 150 a while ago now. We saw that with a study called Orient 31 a year or two ago. This is convincing PFS benefit, in my opinion, over chemo. OS data looks strong. It's immature, but it looks strong. This is better tolerated than amivantamab chemo, in my opinion. So that could be a challenge to amivantamab. This is now the standard of care in China, where this drug has been developed and first trialed. There are global phase 3 studies going on. I know some of those are going to open in London in the near future, and it'd be very interesting to see whether the benefits in the Chinese population are mirrored in the non-Chinese population, Caucasian population. Really interesting. I think perhaps the most interesting of all, as we were literally flying out of ASCO, out comes this press release at the bottom there, saying that first-line ivonescimab by itself is better than pembrolizumab, first-line treatment of PD-L1 high non-small cell lung cancer. It's never been shown before. So we don't know the details, but apparently it's better in terms of PFS. So this is a really interesting drug, and I'll be keeping an eye on this very closely. Icarus is an academic French study looking at datopotamab deruxtecan. This is a TROP2 directed antibody drug conjugate. We saw the data again in ESMO last year. This is using the drug in basically the same way. But as you can see from the dashed arrows, these guys are doing really good tumor biopsies at baseline, blood samples, gene expression. They're looking for IHC. It's a really good French study trying to say who's benefiting and who's not benefiting from this drug. Now, it showed a similar clinical activity to the data that came out in ESMO last year, the Tropion data, but I'm not going to show you that. I'm going to show you some of the activity according to TROP2 expression, because we haven't seen any biomarkers yet for this antibody directed against TROP2. And you can see that if you look at the biomarkers, they're patients with high in red, blue is medium, and green is negative. You get a better response if you have some TROP2 than if you don't. So the beginning of an expression saying maybe that's helpful, but you'll probably notice that the blue and the red are probably the wrong way around. You probably would have thought that a high expressor would do better, wouldn't we? I don't know. There's also some suggestion in these comparatively, in fact, not comparatively, definitely small numbers of some PFS benefit if you have TROP2. So the beginning of how do we try to pick out patients who benefit the most from this drug approach. You may remember from ESMO that patients with EGFR mutation, they did the best. But actually, if you look at the gene signatures, we're not seeing that when you look for genomic alteration. So that wasn't borne out here. So that still muddies the water a bit. So we haven't got an obvious gene to go for yet. But there are some genes activated in patients who don't respond to this drug. DNA repair and some of the genes involved in immune suppression. So maybe that might give us an idea why some people aren't responding. Maybe that gives us an idea of what to add into this drug to try to get people to respond. So why is it so interesting? Because this is the first time people have tried to look at how the drug works and doesn't work. So well done for doing this. Better overall survival in the EGFR mutated population. I didn't show you that, but that's been shown previously. We've seen some signal with TROP2 immunistic chemistry, but I think we need to get a better grip on this and a better clarity on the biomarker. I would like to see some data on who does benefit, not those who don't benefit. But it's a great academic study, and we need to have more of these to understand how these drugs work. I think TROP2 ADCs are working, but I think they're working in a subset of patients, and we don't quite know who they are yet. And so the signal's been drowned out with the people it's not working in, and they're looking a bit modest in their activity at face value. The last study I'm going to show you is the tarlatamab data. So tarlatamab is a DLL3, that's the target BiTE, bispecific T-cell engager. Again, something we went through in ESMO BTOG update last year. Really interesting drug with activity in relapsed small cell lung cancer. Now, that's not something that we say very much. Now, in this study, on the left-hand box, you can see this is relapsed sort of refractory small cell lung cancer, 2 or more previous lines of therapy. So quite heavily pre-treated, right? These guys have had at least 2 lines of platinum or platinum and something else. And what was found in this Delphi study, which was a phase 2 study, was 2 different doses. And in the end, the 10 milligram in blue dose was taken forward. And that's what I'm going to show you data on. And particularly, I'm going to show you data on patients with brain metastases. So this is tarlatamab, relapsed extensive stage small cell. Look at here the overall response rate. On the left-hand column, you've got patients with brain metastases. And on the right, you've got patients without brain metastases, and the response rate is similar. These are small numbers. You can see the duration of response, third line down, similar. Ditto, progression-free survival. We're not quite sure overall survival yet in the brain mets negative group. But I think what this says is this is a drug that has activity still in patients with stable brain mets. That's very important because brain mets are so common in small cell. If you look at the toxicities, looking at maybe the top 5 lines, you will see there's no real difference in the overall adverse events, grade 3 adverse events, and those lead to drug interruptions or discontinuations, 14 and 5-ish% respectively. Now, as Louise has mentioned, there is a challenge of these drugs, which is that they can cause cytokine release syndrome. Now, cytokine release syndrome is caused by the fact it's a T-cell engager. That's the main toxicity of this. There's no difference really in that, but there is an increase in something called ICANS, which is a neurological syndrome you can get with these, often reversible and clearly treatable. But we are getting a little bit more ICANS and neurological events, so we've got to watch that. So what about that activity? Look at the bullet points on left, if I could ask you to do that. Tumor shrinkage in about a third of patients. Intracranial disease control in 94%. But do remember, patients had stable mets going into this. So we take that with a pinch of salt if I were you. And we're waiting to see what that median duration of control is. So what's my take on Delphi 301 and tarlatamab in CNS? Well, look, it confirms the activity of this drug. There's encouraging CNS data, but I think the results are confined by that prior radiation. Lots of people had prior radiation. They had stability. So I think the shrinkage data is important. The stability data, I think we need to find out a little bit more about that. Cytokine release syndrome is the main problematic adverse event. It's going to be a challenge for the NHS to do this. ICANS is neurological syndrome, higher with CNS, but they tend to be lower grade and manageable. I think this will become the standard of care where it's funded in relapsed disease because we have so little else which is effective. But I think it doesn't hide the fact this will be a challenging drug to give. So those are my 5 things. Adriatic, new standard of care in limited stage small cell. Luminosity, Teliso-V, active but toxic neuropathy lungs. Harmony A, really interesting bispecific monoclonal PD-1 VEGF. That's a cracking drug to watch out for, I think. Icarus, really good academic study. Why do TROP2 ADCs work and not work? Don't think it's given us the answer yet, but it's the first step to getting that answer. And then Delphi 301, tarlatamab, update on activity is definitely active, and CNS data as well. So with that, and I think I've kept to time, I have actually, miracle, I'm going to pass over to Riyaz Shah. And Riyaz is going to update us on the other bits and some really interesting data from a number of different studies. Riyaz, thank you very much. Just before you start, I'll remind people, do you put your questions into the chat? I can ask them on your behalf, and we'll have a bit of a chinwag when Riyaz has given us the benefits of his wisdom. Thank you, Riyaz.
Thank you very much, Tom. Welcome, everyone. Thank you for the opportunity to speak again. These are my disclosures. So this is designed to be relevant to UK practice, so it's important to know that because this does go on the internet and anyone around the world can view it. So what I'm going to talk about is some data in the treatment of early lung cancer, and I mean resectable early lung cancer. I'm going to talk a little bit about mesothelioma. Tom, in fact, did small cell by discussing the Adriatic and tarlatamab, so I won't be discussing small cell. I'm going to skate on very thin ice and talk about a radiotherapy trial in oligometastatic disease, and then talk a little bit about the way we communicate immunotherapy toxicity to our patients. So the first thing we want to do is reflect on early resectable lung cancer. You will all know that neoadjuvant chemoimmunotherapy is approved, reimbursed in NHS England, indicated in resectable stage 2A to 3B non-small cell lung cancer, and it's based on this one trial called Checkmate 816 that involves giving 3 cycles of neoadjuvant chemo with nivolumab prior to surgery. And just talking about this trial, so these are newly diagnosed resectable patients meeting the staging eligibility criteria with no EGFR or ALK mutations. Really important to remember, they are stratified by their stage and by PD-L1 status plus or minus higher or less than 1% and sex. And the fundamental randomization for the key primary analysis is the 3 cycles of neoadjuvant chemo-nivolumab or chemotherapy alone, followed by surgery. Now, that standard arm is not something we normally do in the UK, give chemotherapy preoperatively, then operate. It's not something traditionally we've done in the UK, but there is trial evidence to support that. And importantly, a nice study, Spanish study called the NATCH trial that showed that giving chemotherapy pre-op gave the same overall outcomes as post-op. So we don't believe there's a difference between giving chemo before or after surgery in the context of early lung cancer management. So here is a trial of neoadjuvant chemoimmunotherapy, only 3 infusions of nivolumab followed by surgery and no further real treatment-directed, trial-directed therapy after that. What did we know already? Now, this trial has been milked left, right, and center. Every meeting, international conference, there's an update. And I've never seen a trial presented so many times with tiny additional bits of data. So we already knew there was a very high pathological complete response and major pathological complete response to this study, 24 and 36%. And we knew from the forest plots that all patients, regardless of stage, histology, and PD-L1 status, or whether they received carbo or cisplatin, benefited from this approach. We also knew, because they measured ctDNA through the treatment, that patients that had ctDNA clearance, basically that was a much more common phenomenon in patients who were having chemo with nivolumab. And we also know that pathological complete response was very strongly associated with ctDNA clearance. There's also been surgical data showing that patients having the interventional arm had less risk of having a thoracotomy, more minimally invasive surgery, fewer pneumonectomies, no detriment in health-related quality of life. And the key data has been in event-free survival, so up to 36 months, a significant improvement in the event-free survival rate. The median event-free survival hadn't been reached in the investigational arm, and for overall survival, a trend towards possible benefit, but not statistically significant when that was last presented. So that's what we knew already. But last year, we also got some really interesting data at ESMO that we mustn't forget. They actually showed us the outcomes by PD-L1 status. Remember, this is a predefined stratification in the trial design. And here you can see the path-CR rate for PD-L1 expressing tumors, 32%. You can see the event-free survival and the overall survival. And that OS hazard ratio is 0.37. So you see very clearly, wow, PD-L1 positive disease, fantastic result. But look at the PD-L1 negatives. Look at the much lower, almost half the path-CR rate, and an event-free survival and overall survival that looks highly mediocre and doesn't really give you that sense that it's adding much. Now, interestingly, in the FDA have approved this in the overall group, but when EMA looked at this data, they said they didn't like it at all. So in fact, in the European Union, this is only approved in PD-L1 positive disease. So what did we learn in ASCO? Well, they showed us 4-year data on event-free survival. And here you can see now, finally, the median event-free survival has been reached at almost 44 months and a very strong hazard ratio of 0.66. And the landmark at 48 months, 49%, half of patients are event-free because they had 3 cycles of chemoimmunotherapy before their operation. Extraordinary result. And a very strong trend for showing some sort of survival benefit. So if you look at overall survival, the hazard ratio is 0.71. It's not quite statistically significant, but very strongly trending to that. If you look at lung cancer specific survival, it is significant with a hazard ratio of 0.62. Now, some patients were treated with carboplatin, some patients with cisplatin, and you can see clearly that that didn't seem to make a difference. But I think it's very notable and interesting that the standard arms of just chemotherapy, the carboplatin arm does a little bit worse. So I'm a carboplatin user. I gave up on cisplatin many years ago. This has got me reflecting slightly on whether cisplatin has a role. I certainly think from this data it has no role in the context of using combination immunotherapy. We also showed, I've showed you that they've already previously showed a 56% ctDNA clearance rate, but actually the added data was that that was associated with a survival difference. So the survival hazard ratio is 0.31 for nivo chemo in patients that had ctDNA clearance. So what are the conclusions? So neoadjuvant chemo IO is associated with positive outcomes. We've got confidence, 4-year data. I think we can relegate cisplatin into the dustbin in the context of neoadjuvant chemo IO. Maybe we should relook at cisplatin in pathologically upstaged disease because a significant number of patients are going straight to surgery and coming back into our clinics node positive. The ctDNA data is interesting, but we don't really know if it's predictive or prognostic. But maybe in the future, this will be a biomarker that will select us for treatment intensification in certain patients. Now, so that's interesting. But the world in neoadjuvant chemo IO is changing. And it's changing because pharma are very interested in convincing us that we should be giving post-operative immunotherapy. 3 cycles just seems too little. So here we have Checkmate 77T, the BMS study, which is giving 4 cycles of neoadjuvant chemo IO before surgery, but after surgery, giving patients up to a year of nivolumab. And hot on the heels, MSD are saying, no, don't do that. Come and give pembrolizumab. Here's our lovely study, Keynote 671, doing essentially the same thing. The overall treatment here is 3 months before surgery and 9 months after surgery. So a total treatment, systemic treatment duration of 1 year. And AstraZeneca are hot on the heels saying, no, 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 don't listen to any of those guys. Durvalumab, fantastic drug. Please think about our trial, the Aegean trial. The problem with all these studies is they're all excellent. They're all giving us positive outcomes, but they're all very, very similar. And certainly very similar to Checkmate 816. So it's very difficult to see what subgroup of patients are benefiting from going back after surgery and having an additional year of immunotherapy. So there were some presentations at ASCO that I thought were very interesting, focusing on resected N2 disease. So N2 is only stage 3, right? If you're N2, you've got stage 3 disease, either 3A or 3B. And all of those trials allowed resectable patients with 2A up to 3B, but excluded patients who were N3. So this is the absolute one end of the spectrum. The most advanced patients who went into these neoadjuvant studies are represented by the patients who had resected N2 disease. We had a presentation on the Aegean study where they presented the data from patients who were N2. 49% were N2 at baseline, and they showed very conclusively lots of things to reassure us. So the proportion of patients that completed 4 cycles preoperatively was the same, whether they were N2 or not. Slightly fewer patients getting to surgery, but we're talking single-figure percentage points. Slightly fewer completing surgery, again, single-figure percentage points. The R0 resection rate was similar to the rest of the non-N2 patients, and the type of surgery was also very similar. And what you see here is the PathCR rate, the MPR rate doesn't really differ from the modified intention to treat population and the subgroup 49% of patients who are N2. And if you look at the event-free survival curves, it's also very similar. Now, they also showed us the event-free survival hazard ratio for patients with single-station N2 disease and multi-station N2 disease, 0.61, 0.69. So irrespective of whether patients had N2 single or N2 multi, the outcomes were very good in these patients. And their conclusions were that there was a clinically meaningful improvement in efficacy, no adverse impact on surgical outcomes, manageable safety profile. So this perioperative strategy is a potential treatment option for patients with N2 resectable non-small cell lung cancer. And BMS showed us some really interesting data to reinforce this message in their N2 patients from 7017. So 64% of the patients who were treated in this study, 461 patients, were either 3A or 3B, and a significant number of those were N2. So they divided these patients into only stage 3 disease who had N2 disease and only stage 3 patients who did not have N2 disease. And what you see is the path-CR rate in the N2 disease is 29%. The path-CR rate in those resected with single station N2 was 25%, in multi-station N2 was 38%, and downstaging was very common. 57% of patients with N2 disease became N0, and 10% of patients with N2 disease became N0. They also showed us here that in graphical form, so in terms of event-free survival. So you can see that event-free survival hazard ratios are very good in resected N2 disease compared to non-N2 disease. And they were also trying to tease out whether we could show some data telling you what the contribution was of the immunotherapy that's given after surgery. So this is just curves of event-free survival from patients who had surgery after the operation, so forgetting what happened before surgery. So from the point of surgery, you can see that patients with resected N2 disease who receive post-operative immunotherapy do much better than those that receive placebo. You can see that very clearly on the curve on the left. And you don't see that so well in the non-N2 disease. And then if you look at the N2 patients by single station or multi-station, you see that there is that benefit. So this is actually quite, it's hypothesis generating, it's not a stratification, but it's very convincingly suggesting that there might be a specific benefit for post-operative immunotherapy in those high-risk N2 patients after surgery. Now, they also showed that in the N2 disease, the path-CR rate was related to outcomes, event-free survival outcomes, and that was very strongly positive in both single-station and multi-station N2 disease. So they are showing durable event-free survival data for N2, both multi and single-station disease, hypothesis generating, and we need a prospective trial to evaluate this. And I would like to introduce you to the ETOP ADOPT study, which is going to do exactly that, randomizing patients after surgery to post-operative immunotherapy or not. So why do I think this N2 data is interesting? Well, traditionally, multi-station N2 disease in the UK is seen as a marker of being unresectable, that these patients should be getting chemoradiation. It's a huge area of debate. We need to think about the boundaries between resectability and non-resectability. EORTC Lung Cancer Group have done a huge amount of work documenting what is considered acceptable and where the areas of controversy are, and they're in the process of working out a consensus. So I've got 5 minutes to go. Sorry, I whittled on for a bit. So I'll whiz through the rest. So mesothelioma, nivo-ipi is our standard of care. 3 large international trials have looked at chemo-IO versus chemotherapy. And at this meeting, BEAT-MESO was presented.
Recording in progress.
BEAT-MESO is looking at chemotherapy with bevacizumab as the standard arm compared to chemotherapy with bevacizumab plus atezolizumab. Very high crossover rates to immunotherapy in the standard arm of 73%, based on this old study that showed the addition of bevacizumab adds a survival benefit to chemotherapy. Sadly, this trial was fundamentally negative with no survival benefit at all. In terms of overall survival, you could see that in patients with non-epithelioid disease on the right, there was a benefit, but in epithelioid disease, there isn't. But note the very high median survival rates of 21 to 22 months in that group, suggesting that bevacizumab had additional benefit in that group of patients. And again, an association with PD-L1 expression. We don't need to dwell on that. Toxicity was really as expected for a chemo-immunotherapy antivascular combination. And if you put Checkmate 743 up against the 2 published chemo-IO trials, what you can see in the middle, there's a column saying overall response rate. Chemo-IO seems to be associated with a higher response rate. If you look at progression-free survival, you don't see a PFS benefit with chemo with IO only in Checkmate 743, but you do see that with IND-227 and BEAT-MESO, and the survival figures are there. I think it's notable that BEAT-MESO epithelioids seem to have quite a long survival. So chemo IO seems to have a higher response rate, doesn't seem to have the early PFS detriment that you see with immunotherapy only. If you look at the Checkmate 743 PFS curves, the duration of response for IO is very long, 11 months in Checkmate 743 and 24 months in the non-epithelioids having nivo-ipi, so very significant there. So what are the first-line treatment options? Well, immunotherapy is what we have to give, but chemo-pembro or chemo-bev-atezo are options for all of both non-epithelioid and epithelioid. But in epithelioid, I think most people would agree immunotherapy alone is the favored option because it's so effective. And I think you could say that the additional information from Beat Meso is that chemo-bevacizumab, even though we don't have access to it, is a potential acceptable standard for epithelioid mesothelioma. I want to briefly discuss the use of niraparib and dostarlimab in the MIST-5 study. So this is a UK study presented by Professor Fennell, showing some activity for this combination. This is all very early phase. It doesn't really affect you in clinic, but highly interesting. There was a really important trial of oligometastatic disease management in terms of radiotherapy. So there are multiple definitions for oligometastatic disease, and there have been a series of 3 randomized trials showing that in synchronous oligometastatic disease, there is a survival benefit using different criteria for how many lesions. The NRG LU002 study was different. It was looking at patients who had metastatic disease, who had induction treatment with at least 4 cycles, and then became oligometastatic, no more than 3 lesions, and then they were randomized to SABR, stroke surgery, or no SABR. Some of the patients had up to 25 lesions before they started systemic treatment, very high use of immunotherapy. Very important, these patients are randomized after induction SAP. So they may have had polymetastatic disease before they entered. So this is a trial of induced oligopersistence. And sadly, it's completely negative by PFS and OS. So is there a role for OMD and SBRT? Not in induced oligopersistence, but this doesn't detract from any of the OMD data in the synchronous setting that we've all become familiar with. And I just want to plug the Saron trial, which has completed accrual in the UK, a very large trial in synchronous OMD, led by Dr. McDonald at the Maidstone, hopefully waiting for those results. The last thing in the last few minutes, I love this. I'm going to get all lovey-dovey because I know you love it. We're going to talk about how to communicate with patients. This session really captivated me. The chap called Professor Toby Campbell, I've never met him before. He's at the University of Wisconsin, spent 15 minutes talking to us about how he talks to patients who are starting immunotherapy treatment. And, you know, it's quite complicated, isn't it? All these different toxicities, you've seen those charts, and itis in any organ, and complex kinetics of when they can start, when they may stop. It's a very difficult discussion. So he introduced this idea that he called Immunotalk, of having a graphical thing that you can show a patient and walk through, both verbally and visually, and get the patient to understand that toxicities can be mild, moderate, severe, what the frequency of those toxicities were, and what we might do to treat a patient. So he draws this little thing in clinic, and then he fills it in with smiley faces or unhappy faces, and he starts filling it in. And he will say things like verbal elements. So, you know, there's a significant number of patients, say 4 out of 10, who will get no toxicity from treatment. You'll just turn up for your treatment every 3 weeks, every 6 weeks. You won't notice anything. You'll be able to carry on work. It's not going to change how you feel. Fantastic. Then he talks about mild toxicities. You know, 3 out of 10 patients will get some mild side effects. This might be something you notice, a mild itch. It might be something I notice, mild derangement in your bloods, and it will be managed. We can get on top of it. It will allow us to continue treatment. You won't have to stop treatment. And then more moderate toxicities, fewer patients. These things are going to be more serious. You might, for example, notice that your bowels are opening 10 to 15 times a day because the immune system's inflaming your colon. This is serious. You will know that something's wrong. You need to contact our department. I may bring you in. I may stop your treatment. I may give you high-dose steroids. I may admit you for investigations. And then severe toxicities, you know, rare, but taking patients through really, you know, this thing could affect your heart function, your brain function, lung function. This is emergency situation, inpatient stay, potentially life-threatening and maybe even fatal in 1 in every few hundred people. So a very nice graphical way of explaining to a patient in a few minutes. The challenge is, can I explain all of this in 3 to 5 minutes to a patient that I'm just seeing as a new patient in my clinic? Well, has this helped me in clinic? You know what, actually it has. I've tried it. This week, last 2 weeks, I've used this in my clinic with a few patients, and I found it quite helpful. I need to learn. I'm just trying to incorporate it still, making it a fluid conversation with patients, but I found that very helpful. That's all I'm going to say. Thank you very much.
Yes, thank you very much. I absolutely agree. I think that last talk was fantastic and unusual for ASCO to focus on something like that. So I wonder if we could welcome the two other speakers back in, Louise and Riyaz. I've got a couple of questions I want to go through in the last 10 minutes or so, and thank you both for keeping to time so well. Right, Louise, I'm going to kick off with you to give Riyaz's vocal cords a brief rest. Laura, one thing that struck me about that study, and just to remind people, this is EGFR mutated lung cancer for which people are having chemoradiotherapy plus or minus adjuvant osimertinib. What struck me is how appallingly bad the control arm did. So EGFR mutated patients having chemo-rad, that survival curve falls off the cliff. What wasn't mentioned in the discussion of the meeting was that PET scans were not mandated, which I think we would find as unusual in someone who's got locally advanced disease. What is your take on that very poor survival curve? Do you think that is a feature of people being inadequately staged, or do you feel that's actually a feature of this, which is a nasty disease, and it comes back very quickly?
Thanks, Tom. I think it's a bit of both, if I'm honest with you. I think that EGFR targeted advanced non-small cell lung cancer is a difficult disease to treat. I think we know that these patients present, with micrometastatic disease, which is very difficult to pick up. So by the time they do exhibit any type of clinical symptoms, they've got brain mets, bone mets, and they've got widespread disease, which is a challenge in itself to treat. And so I think you're absolutely right in terms of, whether we would stage and do a PET scan, and certainly they didn't do that. I think they did this bog standard chest, abdo, pelvis CT scans with then baseline MRI scans and then serial MRI scans after that to check for the development of brain metastases. And I think that clearly, you could potentially miss micrometastatic disease. And I think that goes to the point of, when we're identifying these patients, using ctDNA, and should be, is there a better way to select these patients and, for who need, this type of concurrent type of treatment. So I think it's a bit of both.
Yeah, no, I think that's true, and I think just to give people an idea why PETs weren't done, a lot of patients were recruited from China, where the standard approach to staging is a liver ultrasound and a bone scan. What about the ideal world where we have alectinib, brigatinib, and lorlatinib available to us? We don't at the moment. Just to remind people, lorlatinib is NHS funded, NICE approved, as a second-line treatment after alectinib or brigatinib. If you had all three available, what would you choose? Are you convinced by that extraordinary PFS benefit and that incredible neuroprotective effect of lorlatinib, or do you think that tox isn't really worth it, and do you quite like having another TKR up your sleeve, and so in fact you're going to use alectinib or brigatinib?
So for me, this 5-year survival results from the Crown is quite incredible, and for me that is immediately practice changing. So if I saw a patient tomorrow and I could get access to all three drugs, I would give lorlatinib in the frontline setting. I've had experiences with these hypertriglyceridemia, hypercholesterol, patients, and essentially if you modify the treatment dose quite early on, when you start off these patients, you actually find that the adverse events are actually quite tolerable, and they're actually okay to manage. And they did do that in some of the population of patients, and what they actually found was that there wasn't any change in terms of the PFS anyway, long term. And certainly that was in the first 16 weeks of starting the treatment, which is where a lot of these initial side effects and adverse events occur. And so for me, no brainer, Tom, I would start lorlatinib.
And I think it's a very good point about that introduction. Riyaz, are you a Lorla convert? In the ideal world,
important to recognise that it is reimbursed in Scotland, so Scottish oncologists can prescribe first-line Laura. I agree with what Louise has just said. For me, this is really paradigm shift. Remember, the PFS levels out at a 40% for brigatinib and alectinib. and this is 60%. So there's an additional 20% of patients who are progression free. And the very, very few people from 3 to 5 years, almost no patients have relapsed with brain mets who are still disease free at the 3 point. I mean, it's absolutely extraordinary. So extraordinary, you might even argue you don't need to do MRIs of the head anymore if the patient's stable at 3 years on lorlatinib. So for me, it's the standard of care now. We need to get it reimbursed. I just don't think it may not be for everyone. I think there's a discussion to have with your patients.
Yeah.
But my sense is first line lorlatinib is not as bad. When you give it in the second line setting, it doesn't feel like a great drug. And it doesn't feel like a great drug because we drag out the first line drug for as long as possible before we make the switch. We make the switch when patients are poorly.
Thank you very much. We're going to move on to talking about patient selection and choosing the right people to oligometastatic disease. So, Riyaz, you showed us the LU002, I think it was, study, the oligometastatic study, academic study. That comes on the heels of 3 previous studies, all showing a survival benefit with treatment of oligometastatic disease before the immunotherapy era. We now have a study saying actually there's no survival benefit in the oligometastatic era when 90% of patients had immunotherapy as their systemic treatment. But there are various caveats to that, including we weren't so clear on what the radiation was, we weren't so clear what the surgery was, we weren't so clear on what the treatments were. Does this mean OMD, oligometastatic disease, is dead? Or do you still feel it has a role, or should we stop doing it until we know the results of the excellent Saron study, which you referenced?
No, this is really, really important, right? This trial is a completely different question to the other trials. So other trials are questions of OMD, treatment of OMD, synchronous oligometastatic disease. So the patient presents and has oligometastatic disease and then gets systemic treatment and randomized to radiotherapy or not. But at baseline, they met the criteria for OMD at presentation. Right, so they had one trial is 3 mets, the other one is 5 mets. They all have slightly different definitions. Mm-hmm. This is a trial of any level of metastatic disease. As I showed you, some of the patients had 25 mets, and they had induction chemo IO largely, and then after the 3-month scan, they had 3 mets, and they went into this study. So induce oligopersistence, which is what this is testing. Don't do it. No evidence to support it. In the immediate setting, as per this study. Those other trials are a completely different setting. They're not to be confused.
So that wouldn't change your current practice?
No, I think careful, judicious selection of patients for OMD level treatment is perfectly appropriate.
Okay. And what about the PD? I thought that PD-1 data, PDL1 data was really striking. So just remind people, the Checkmate 816 study, that is the study which backs up our currently licensed and available use of nivolumab plus chemo neoadjuvantly. The benefit in PDL1 negatives was much less. The European license is PDL1 positives only. The use in the UK, because of course we're no longer part of the EMA, and in North America is anyone. Who's got it right, Riyaz? Are we over-treating people who shouldn't be getting neoadjuvant chemoimmuno, or actually should we be reveling in another Brexit benefit?
Well, I mean, you look at those curves, and you could argue very strongly that this is a treatment for PD-L1 positive disease. I just don't think, I think there's a fundamental difference between the way FDA is working, which is saying it's not for us to describe the subgroup that doctors should prescribe a treatment. The trial was done in this group. We're going to approve this group, and doctors can individually decide what they want to do. The problem with that is that then allows for permissive use of these options in guidelines, and many oncologists will just read the guideline and do what the guideline says without realizing what they're doing necessarily. I think EMA is taking a slightly different approach. It's saying, well, actually we want, and they've done this several times. So if you look at adjuvant immunotherapy, it's only approved in greater than 50%, right? Yeah. By EMA, because the Swiss did it first, and then EMA looked at it, and we've copied that. So there's a history now of EMA sort of drilling down and asking difficult questions of pharma and asking them to show data that they haven't offered initially. Remember that a lot of, for example, MPR data, all the MPR data you see includes patients who've had a PathCR.
It does. It does.
They're included in that. They're not showing you just the MPR non-PathCR patients.
Correct.
So pharma can play all sorts of tricks with us, and we need to be conscious of it.
Good answer. Right. So, Louise, I'm going to ask you to tell me your favourite presentation or your favourite data from ASCO 24. And I'm also going to ask you, and this is going to spring this on you, what's a top tip for someone who's going to go to ASCO next year? What tip can you advise them if they're going to go?
Okay, so my favorite data that came out this year, I have to say, I think it was Laura. For me, immediately practice changing in our unresectable EGFR mutant advanced non-small cell lung cancer. I think this is the little forgotten group that hasn't been able to access, EGFR TKIs, and now they've been welcomed into the group with big arms, and it's the way we should be doing
big
it.
alternative arms.
Absolutely. So,
and what's your top tip for someone going to ASCO for the first time?
So top tip. So what I did do differently this year, which I have to say, I think really helped. I think the fact that I knew I had to do this meant that I sat down before I went to ASCO, looked at the agenda, highlighted the things that I thought would be interesting, synced it with my calendar, and it just meant that I could turn up at the right time, got the data that I needed to go, and at the same time enjoy myself with my friends.
Yeah, that's great call. It's quite easy not to do that, but I think trying to be
Absolutely.
prepared if you can. Riyaz, what's your top abstract and what was your top tip visiting ASCO?
So, I mean, I was really taken by the Crown data. I loved it. But, I just think Laura's fantastic, Adriatic's fantastic. Those three are amazing. Crown, for me, I have quite a lot of outpatients, so it sort of does inform what I do in clinic. Top tips for ASCO. The number one thing I'd say is if you ever get an invite to go to ASCO, don't turn it down. It's the most extraordinary meeting. If you want to get away and just feel just re-infused about being an oncologist, about what you do, about the link between science and what you do in clinic, nothing beats ASCO. ESMO's actually at the same level. Take a fleece, wear trainers, and plan ahead because it's overwhelming.
Good call. And my addition to that is eat lots of vegetables before you go because they're very hard to find in Chicago. Okay, we're going to move back to the slides if that's okay, please, technical crew, whilst we thank my excellent panel for their contributions, Louise and Riyaz. It really is a huge amount of work. ESMO and World Lung, would you believe it, they're basically 1 week with the sequential weekends in a moment of complete madness by people organising it. So sometime in September, we will be doing an update on World Lung and ESMO, so that to be confirmed. Please don't forget to do your feedback from today. There's also a brilliant mesothelioma update coming into December. Now, Riyaz organised the one 2 years ago. Can't believe it was 2 years ago. It's unbelievably popular. It was one of the best feedbacks we've had from any meeting for a very long time. So this is in combination with our friends in Mesothelioma UK. That's going to be the 9th of December in the Cavendish Conference Centre in central London. So put that in your diary. It's a really, really good day. That's our next in-person event. And I think that's it. My slide's gone blank. So it must be that's the last one. So thank you very much, you all, for joining us. Thank you very much to Louise and Riyaz again. And to remind you that this will be available on the BTOG webcast webpage. You can see if you are an ASCO member, it's very expensive, but if you are, it is a fantastic resource and you can download all the slides directly off that, but it will cost you an arm and a leg to be a member for a year. So if you can't afford that, hopefully this meeting has been helpful, and thank you very much for joining us.